Okay, last sound check. Hal, are you there?
Yes.
Paul, are you there?
Yes.
Peter, are you there?
I'm here.
Excellent. All right, so let's give it a start. People will join us as they come online. That's not a problem. So good evening, ladies and gentlemen. We'll be starting the session in about a minute. My name is Joseph Galley, and I'm the co-founder and director of the Loeys Dietz Syndrome Foundation of Canada and a director of the U.S. Foundation as well. This is a joint initiative of both the foundations in Canada and the U.S., and I'd like to welcome my partner, Gretchen Oswald, who sits on the board in Canada and is the president of the U.S. Foundation, and she's sitting next to Dr. Dietz right now, encouraging him. I'd like to start by thanking Dr. Peter Armstrong for his openness and interest in holding this webinar event and giving us one of his management meetings. We met at POSNA earlier this year, and Peter was very receptive to learning about Loeys Dietz syndrome. We had numerous discussions over the summer and concluded that Shriners is in a unique position as your organization sees thousands of patients a year who have the disease, and because of the musculoskeletal and related type of features. We've undertaken a multi-pronged strategy to create awareness, foster research, and provide support for patients, families, and the medical community. In this light, the pediatric orthopedic community is considered for us to be the tip of the spear in identifying Loeys Dietz patients. As we'll see tonight, many of the LDS patients have musculoskeletal conditions that orthopods see and are not aware of. So tonight our objective is to provide you with information on Loeys Dietz so that you can help identify patients with this rare but deadly disease. I'd like to say that not only does the Shriners do fantastic orthopedic and burn work, but now you'll be able to help us contribute to saving the lives of patients with LDS by identifying them early and with correct diagnosis. And prior to putting together our strategic plan earlier this year, we interviewed 40 of the top researchers, doctors, people with the disease, families, and parents of children that have passed away from the disease. And it was very clear that the one thing that we could do that would have a major impact on this community was early and correct diagnosis. And that's what our objective is. And that's where we see working together with your institution as being a key contributing factor to this. This is personal for me as my wife and two of my sons have Loeys Dietz. They're treated in Montreal at the Shriners. We consider ourselves extremely fortunate to have the great care that we have, and that's what's led us to developing a relationship, which we'll perhaps talk about a little bit more later on. Shortly, I'll pass the mic to Dr. Armstrong, who will open up the session. Then Dr. Hal Dietz will give us his presentation, which should last about 20-25 minutes. Then we'll move on to Dr. Paul Sponseller for 20-25 minutes, and then we'll have a question and answer period where you'll be able to raise your hand. You'll see a little hand at the bottom of the participant panel. And as you click on that, it'll light up next to your name, and it'll put it in sequence of order, and I will be able to turn your mic on when it's time to ask the questions. The session is being recorded, and the recording plus the presentation material will be made available to all attendees after the session, and we'll coordinate that through Dr. Armstrong's office. So, Peter, is it okay if I turn it over to you to make the introduction?
It is. Do I have the mic?
Yep, you're the man.
First of all, just to add a little moment of levity to this, I would like to personally, on behalf of those of us who live in Tampa, Florida, thank Hal and Paul for what the Baltimore Orioles did last night. That put us into the playoffs. Having said that, now we'll get serious again. As Joseph mentioned, he and I had the opportunity to meet and sit down and talk at POSNA in Montreal, and I was fascinated to learn about this syndrome. You know, I've been out of clinical practice now for, this is my 12th year, and this is a syndrome that was identified and characterized by Hal, playing a big role in that back in 2005. And as Joseph and I spoke, you know, I thought the mission of Shriners Hospitals for Children in all that we do is the same as anyone who works in pediatrics, and that's to provide the very best care to the children who come to us. And as Joseph explained it to me, the challenge with this syndrome is that there are a lot of people who don't know about it. Therefore, the kids with this condition are misdiagnosed, and that has a potential for significant complications up to and including death. And so I really felt that it would be very good if we then did an educational session for our surgeons, anesthesiologists. I noticed Kathy Murray is on. She's one of our radiologists. And to make people aware. Now, I was interested to find out that there are 2 or 3 people when the initial announcement went out wrote back to me and said that they in fact have a patient with Loeys Dietz syndrome. So we began the plans to do this seminar, and I would like to personally thank Hal Dietz and one of our colleagues in the pediatric orthopedic world, Paul Sponsler, for taking the time out of one of their evenings to educate us on the Loeys Dietz syndrome and the characteristics, and so the Shriners is very knowledgeable, and we will not be included in the group that misdiagnoses this syndrome. I'm excited about it, and I'm looking forward to hearing from our honored guests. So I'll turn it back to you, Joseph.
Thank you very much, Peter. Appreciate it. So our first speaker, Dr. Hal Dietz, is the Victor A. McCusick Professor of Genetics and Medicine, investigator at Howard Hughes Medical Institute. He's got a BA from Duke, a medical degree from SUNY Upstate Medical Center. He did his residency in pediatrics, a fellowship in cardiology, and a postdoc all at Johns Hopkins. Dr. Dietz was recently voted to the National Academy of Sciences, and as the name, and I'm not sure how it got to be Loeys Dietz as opposed to Dietz Loeys. Maybe Hal will share that with us afterwards. Co-discovered the genes related to LDS with Dr. Bart Loeys, who's now at the University of Antwerp. Most of all, Hal's a terrific guy. He's got a big heart, and he's very focused on the kids, and he's a great supporter of the foundation. We really appreciate that. So thank you very much for taking the time tonight, Hal, as well as the practice sessions and putting up with me as I tried to get all of this organized. So Hal, I'm going to switch the ball over to you now.
Okay,
and, that way you can lead us from here.
All right. Can you help me get to my slide presentation?
All right, Hal, so are you, do you have sharing? And we're going to look at, you're now the presenter.
So it's still showing the intro slide.
Yeah. That's only, so can you go and do share application?
Sure. I'm sorry, everyone. I'm trying. Just one moment.
You're good, Hal. You're on your way. The screen is changing. And we have your slide up and ready to go.
Thank you.
Thank you.
So I'd like to thank everyone for taking time out of their busy schedules to join us to learn more about Loeys Dietz syndrome. As Joe and Peter mentioned, one of our primary goals tonight is to increase awareness and early recognition of this condition. I'm going to start by giving a brief background about a related disorder called Marfan syndrome, and the relevance of that information will become apparent shortly. So as all of you know, Marfan syndrome is a systemic connective tissue disorder with cardinal features in the ocular, skeletal, and cardiovascular systems, including dislocation of the ocular lens shown on the left, long bone overgrowth, but most importantly, progressive dilatation of the root of the aorta at the level of the sinuses of Valsalva that will lead to aortic tear, rupture, and early death if left untreated. The panel on the left shows what we knew about the cause of Marfan syndrome prior to 1990. It's an elastin stain of the medial layer of the aorta, showing long, parallel, densely packed elastic fibers in the normal sample on the top, with fragmentation and disarray of elastic fibers in someone with Marfan syndrome. In 1991, we were able to show that mutations causing Marfan syndrome occur in the gene that encodes the connective tissue protein fibrillin-1. We learned that fibrillin-1 molecules aggregate to form complex extracellular structures called microfibrils, and that microfibrils cluster around the maturing ends of an elastic fiber during embryonic growth. This simple spatial and temporal relationship led to the firm belief that you need a lattice of microfibrils to form an elastic fiber during embryogenesis. And this was really a very pessimistic view. It suggested that a child with Marfan syndrome is born with inadequate elastic fibers, and that they therefore have an obligate structural predisposition for the tissues to fail later in life, that there's nothing you could do after birth. In the next slide, I'm going to show you a molecular pathway, and I will be brief with this, but it really highlights the potential for new and exciting therapeutic strategies for Marfan syndrome, and as I'll explain later, for Loeys Dietz syndrome. So we learned that microfibrils, can you see my cursor as I move it?
Yes.
Yes, okay. So we learned that microfibrils that are composed of fibrillin-1 serve an important regulatory function in that they bind the inactive complex of a growth factor molecule that's called transforming growth factor beta, or TGF-beta. We also learned that in Marfan syndrome, where you have a deficiency of microfibrils, there's inadequate matrix sequestration of TGF-beta, and that this leads to promiscuous activation of the growth factor that can then go on to set in motion an intracellular signaling cascade that ultimately results in accumulation of a molecule called phosphorylated SMAD2 or SMAD3 in the nucleus. And most importantly, this excessive TGF-beta activity had phenotypic consequences. It resulted in the emphysema seen in Marfan syndrome, the mitral valve disease, the aortic aneurysm, and also skeletal muscle myopathy. And we knew this because all of these phenotypic features could be greatly attenuated or even prevented in Marfan mouse models simply by injecting them with TGF-beta blocking antibodies. We then went on to ask whether there was a drug that might mimic this protective effect, and our attention turned to the angiotensin receptor blocker losartan that lowers blood pressure, something we think is good for people with aneurysm, but had also been shown to block this TGF-beta molecule in rodent models of chronic kidney disease. We went on to treat our Marfan mice with losartan, shown in the bottom panels, and we learned that this treatment resulted in full normalization of the architecture of the vessel wall, a full normalization in aortic size, prevention of pulmonary emphysema, and also normalization of skeletal muscle architecture, fiber number, size, and strength. So there are now large multi-center clinical trials of losartan in Marfan syndrome in people that are going on worldwide. So about 6 years ago now, my colleague Bart Loeys and I recognized and described a new aortic aneurysm syndrome that had many features like Marfan syndrome, including curvature of the spine, pectus deformity, arachnodactyly, and aortic root aneurysm, but also that included many unique features, including widely spaced eyes, a cleft palate and or a bifid uvula, craniosynostosis, clubfoot deformity, and multiple forms of congenital heart disease, such as patent ductus arteriosus, bicuspid aortic valve, or atrial septal defect. Most importantly, these individuals have diffuse tortuosity of their blood vessels. On the left, you can see the aorta is making a hairpin turn behind the heart, and the carotid arteries are making pigtail turns as they go up into the head. These patients also develop aneurysms throughout the arterial tree, not just at the aortic root, but at many sites throughout the body. Importantly, these aneurysms tend to rupture at young ages and at small dimensions when compared to Marfan syndrome. To date, we have personally cared for over 200 families with this condition that's referred to as Loeys Dietz syndrome. Now, based upon what we learned about Marfan syndrome, we thought that Loeys Dietz syndrome would also relate to an abnormality in TGF-beta activity. And indeed, the very first two genes we sequenced were the two genes that encode the receptor that sits on the cell surface and that binds to TGF-beta. We've now learned that the vast majority of patients with Loeys Dietz syndrome, greater than 95%, have mutations in either of one of these two genes. By mechanisms that we still don't fully understand, these mutations lead to an increased level of activity of TGF-beta in the aorta and in other tissues. On the right, I'm showing you aortic tissue from a control individual and from someone who had surgery for Loeys Dietz syndrome. We're looking at phosphorylated SMAD2, which shows up as the brown stain. And if you look at the magnified insets, you can see that there's a great increase in the patient with Loeys Dietz syndrome compared to the control. I think it's very important to review the outward features of Loeys Dietz syndrome that would allow orthopedists and other specialists to identify individuals that are likely to have this condition or that at least warrant molecular testing. Only about 12% of patients have craniosynostosis, about 60% have hypertelorism, and 22% have cleft palate, which could either be a total cleft or a submucosal cleft. Interestingly, I think the lack of a cleft lip is a specific feature of Loeys Dietz syndrome. We have never seen a patient with Loeys Dietz syndrome that has cleft lip. These patients have a variety of abnormalities of their uvula, ranging from a complete bifid uvula to a broad uvula, uvula with a midline raphe, or even an especially long uvula. Exotropia is common in these patients, as is a blue or dusky appearance to the sclerae. On the top here, I'm showing you a patient with very typical severe craniofacial features of Loeys Dietz syndrome, but I want to stress that this is not a uniform finding. For example, the young lady shown in the bottom also has a Loeys Dietz syndrome mutation, but has none of the craniofacial features. She does have arterial tortuosity and mild aortic enlargement at this age. And this has led to two different designations, Loeys Dietz syndrome 1 with severe craniofacial features and Loeys Dietz syndrome 2 without the severe craniofacial findings. There are a number of findings that are often quite evident, especially in young children. You can notice in the top panels that these children do have a blue or dusky appearance to the sclera of the eye. And the appreciation of this vein crossing the nasal bridge is often a very striking finding, especially in young patients. On the bottom, I'm also demonstrating that exotropia is also quite common in this population. As I mentioned, uvulas come in many flavors, ranging from a simple broad uvula on the upper left an even broader uvula in the next image, a uvula with a midline raphe, with a minor distal split, ranging all the way to an apparent double uvula that's seen in the lower right. Paul Sponseller, my friend and colleague, is going to go over the skeletal features in a lot of detail. I'll just cover them briefly here. Certainly, as in Marfan syndrome, pectus deformity is quite common, most often excavatum, but carinatum is also seen. Scoliosis is common and often does require surgical management, and most patients with Loeys Dietz syndrome have significant joint laxity. Interestingly, unlike Marfan syndrome, many patients with Loeys Dietz syndrome are not particularly tall and are not taller than their unaffected family members. The mean arm span to height ratio is 1.03, which would be perfectly normal, whereas in people with Marfan syndrome, this ratio would typically be greater than 1.05. The upper to lower segment ratio is also normal in this population, with the mean being 0.9. So only about 21% of people with Loeys Dietz syndrome show evidence of long bone overgrowth or dolichostenomelia, and if they do show it, it tends to be mild versus the majority of individuals with Marfan syndrome. As I mentioned, the patients are not particularly tall. Their height Z-score is about 0.5. Versus 2.0 for Marfan syndrome, so well within the normal height distribution. We often see arachnodactyly. Joint contractures, I believe, are more common in this condition than in Marfan syndrome, although contracture can be seen even in Marfan syndrome, especially in very severely affected young children. About 34% of individuals with Loeys Dietz syndrome have a personal history of club foot deformity. This is not always fully penetrant within families, so often we'll be seeing a mildly affected individual, but here that multiple relatives have club foot deformity. And even in those that don't have clear club foot deformity, forefoot varus is quite a common finding, as is simple pes planus. Many of these patients have significant cervical spine malformation or instability, about 40%. We've identified this in all age groups, and this often does warrant surgical stabilization. Such stabilization can be complicated by poor bone healing, requiring prolonged halo use, for example. And this is particularly common in people with a history of osteoporosis and pathologic fracture, which is a manifestation of Loeys Dietz syndrome. So we believe that the initial evaluation, the diagnostic evaluation, should include flexion and extension neck films and a DEXA scan. The skin is generally involved in Loeys Dietz syndrome, often having a thin and translucent quality with easily visible underlying veins, as shown in the lower right. The skin often has a smooth, velvety texture. Most patients describe a tendency for easy bruising or dystrophic scar formation, as shown on the upper right. About half of patients have a history of hernia, and about 60% have dural ectasia. So dural ectasia is about as common in Loeys Dietz syndrome as it is in Marfan syndrome. As I mentioned, arterial tortuosity is common. In fact, we think this is a very useful diagnostic finding. And we would often do a three-dimensional CT or MR angiogram in a diagnostic evaluation. It's seen in about 92% of patients, and most often is prominent in the head and neck vessels, particularly the involvement of the carotids and vertebrals are often seen. The ascending aorta and aortic arch in the lower aorta and branch vessels can also show tortuosity. We don't know that tortuosity is clearly indicative of a problematic vessel. It's so common that we don't think that it has great prognostic significance in this patient group, although we have seen unexplained stroke in 2 patients. Aneurysm is, as I mentioned, very common, widely distributed, and often very early in this disorder. At the time of diagnosis, close to 90% of patients have aortic root aneurysms. 27% would have involvement of the more distal ascending aorta, which is not typical of Marfan syndrome. The aortic arch and the descending thoracic and abdominal aorta can be involved. About a third of patients have vessel involvement beyond the aorta. So we do believe that there should be a MRA or CTA from the head through the pelvis at the time of diagnosis. We would repeat this about every 18 months and make particular use of MRA studies on a regular basis in order to avoid radiation exposure, but prefer CTA of the head because of a lower rate of false positive calls by CTA as compared to MRA for evaluation of the head. We would certainly do more frequent evaluations if there's a particular vascular issue that's being followed. As I mentioned, other cardiovascular findings include patent ductus, atrial septal defect, bicuspid aortic valve, and mitral valve prolapse. The aortic root is often very enlarged, especially in young children who are already requiring attention and not simply because of a positive family history. Young children that make themselves obvious to us at an early age tend to have more severe vascular disease, so their vascular involvement parallels their systemic involvement. We do recommend an echocardiogram at least once a year for these patients. Aortic dissection can also be an early presenting finding. It's present at diagnosis in about a third of patients with a mean age of 24 years and a range of 6 months to 44 years. There appears to be a slightly higher tendency for early dissection in male patients, as is seen in many vascular conditions. And again, the dissection most commonly involves the root, but also can involve other aortic segments. So mean age of elective repair in these patients is 19 years. Mean age of more distal aortic arch repair is 30 years, and for descending thoracic aortic repair is 25 years. Fortunately, these patients have shown a truly phenomenal response to cardiovascular surgery. Initially, when we first recognized these conditions, this condition, we worried that these patients might behave similarly to individuals with vascular Ehlers-Danlos syndrome who have a very high rate of operative complications. But now, having done over 100 prophylactic vascular procedures in this patient group, we've seen 0 in-hospital deaths for elective root repairs, 0 late deaths for elective repairs, and 1 total operative death. That was a very complex redo arch repair. So we've continued to try to use mouse models of vascular conditions to explore new therapeutic strategies. And we've now gone on to introduce specific disease-associated Loeys Dietz syndrome mutations into mice in both the type 1 and type 2 receptor subunit. As you can see on the bottom, Loeys Dietz syndrome mice have much larger aortic root sizes when compared to their normal or wild-type litter mates, shown in blue. and that Loeys Dietz syndrome mice show a significant reduction in aortic root size and aortic root growth rate when treated with losartan. So we do think that this therapy that has been pioneered for Marfan syndrome will show relevance to this patient population. Fortunately, the Loeys Dietz syndrome mice nicely recapitulate nearly all aspects of the disease, including the skeletal phenotype. As you can see, when compared to a normal or wild-type mouse, the mouse line with a mutation in the type 1 receptor subunit or the type 2 receptor subunit shows significant kyphosis and also show overgrowth of the ribs. So we do think that these mice can be used to explore the driving mechanisms in orthopedic disease in this condition, and also will be useful to explore potential medical therapies. We don't yet know whether some of the therapies that have been developed for Marfan syndrome will influence the skeletal system. But we've had more experience with the Marfan mouse model. Here again, I'm showing you a normal mouse on the top and a Marfan mouse on the bottom. And you can see, once again, this very prominent kyphosis and rib overgrowth. We recently went on to treat these mice with losartan. This is an intermediate result. They will be treated for a longer period of time. But we do actually see some subtle evidence of a reduction in the kyphotic curve, and this does correlate with a significant reduction in total spine length in these mice. So at least a hint that there might be medical strategies that could be used to manage orthopedic issues. So medical management of vascular disease in Loeys Dietz syndrome, it's now wide practice to use losartan because it's FDA approved and very well tolerated for other indications. Importantly, this medication is not simply being used to lower blood pressure, so you really have to use aggressive dosing to hope to achieve a reduction in TGF-beta activity. These patients should have exercise restrictions with specific avoidance of contact sports, competitive sports to the point of exhaustion, and isometric exercise that involves muscle straining, but should remain active with aerobic activities that are performed in moderation. And again, we do believe that there should be frequent and widespread cardiovascular imaging. Surgical management of the aortic root, we now have excellent success with a valve-sparing aortic root replacement, allowing these patients to avoid chronic anticoagulation. In patients that have the most severe presentation at very young ages with severe craniofacial manifestations or with known mutations that are associated with very severe disease, we move ahead with surgery simply when the aortic annulus is big enough to accommodate a graft of sufficient size to take that child through growth. So we're really not following the aortic root size, but rather waiting until the aortic valve is at least 2 centimeters in diameter that allows a placement of a good size graft. In patients with more run-of-the-mill Loeys Dietz syndrome, or if pregnancy is anticipated, we would do root surgery at about 4.0 centimeters. And in patients who are least predisposed based upon subtle systemic manifestations, family history of mild disease, or mutations that are known to be associated with more mild disease, we would do aortic root surgery at about 4.5 centimeters. Surgical management of other vascular issues really depends upon the site, the nature of the lesion, and its accessibility. In general, when compared to the general population with similar vascular lesions, we would use a more aggressive approach in this patient population, and both operative and intravascular approaches are considered. We do know that pregnancy is a risky proposition in women with Loeys Dietz syndrome. In a very early experience, we assessed 21 pregnancies in 12 women. 6 had major complications during pregnancy or postpartum that included 4 aortic dissections or 2 uterine ruptures. And there were also 3 individuals who had uterine hemorrhage that required surgical management independent of pregnancy. This clearly needs to have further study, but if a woman with Loeys Dietz syndrome does make the decision to become pregnant, we would recommend an echocardiogram every 2 to 3 months. We would recommend that that woman be followed by a high-risk obstetrician, and we would also need to take her off an angiotensin receptor blocker such as losartan for the duration of the pregnancy because they can have, such medications can have teratogenic effects. Interestingly, there are some other systemic manifestations that can provide a clue to a patient that has Loeys Dietz syndrome. We've recently recognized a very high prevalence of allergic disease in this patient population. For example, patients with Loeys Dietz syndrome, about 48% of them have seasonal allergy or allergic rhinitis. Nearly half have medically managed asthma. About 40% have eczema. 30% have food allergies that tend to be multiple and severe, often requiring use of an EpiPen. And about 10% of them have eosinophilic esophagitis, or even a picture most consistent with inflammatory bowel disease. And if you look on the right, this represents tremendous enrichment in Loeys Dietz patients compared to the general population. We are currently doing work to better understand this predisposition, but it's now clear that there is altered maturation of the immune system, promoting a very pro-inflammatory predisposition in these patients. Fortunately, our Loeys Dietz syndrome mice do spontaneously develop these allergic phenotypes. Here I'm showing you this very inflamed esophagus in a mouse with Loeys Dietz syndrome compared to its normal litter mate. And on the right, I'm showing you that this inflammation is characterized by intense infiltration of eosinophils. So we really do think that the Loeys Dietz mouse model is not going to only be informative about the pathogenesis and treatment of vascular disease, but will also inform the management of other systems. There are a few other manifestations of Loeys Dietz syndrome that need to be considered. Many of the severe young children have dental anomalies, including enamel hypoplasia with severe tooth decay and delayed tooth eruption. Headache is much more frequent in Loeys Dietz syndrome than it is in the general population. It tends to have a vascular quality, a migraine type history, and it's very important to counsel these patients to avoid vasoconstrictors such as triptan medications. We now have a number of examples where patients with Loeys Dietz syndrome have suffered vascular dissection and death in association with the use of triptans for headache management. Seizure is a rare manifestation of Loeys Dietz syndrome. It certainly deserves a full neurologic workup when it's seen. Initial reports suggested that learning problems were seen in about 15% of people with Loeys Dietz syndrome, but this is now obviously an overestimate now that we've seen a broader spectrum of this condition. And when seen, it's largely secondary to hydrocephalus or other definable causes. And about 6% of patients have symptomatic Chiari malformation. So summary of Loeys Dietz syndrome specific management: maintain a high index of suspicion, including any patient with atypical findings in Marfan syndrome or other vascular conditions. Pay close attention to even subtle craniofacial, skin, orthopedic, and imaging findings. And when in doubt, sequence the genes. It's a very sensitive and specific test. The diagnostic evaluation should include three-dimensional imaging from the head to the pelvis and certainly imaging of the cervical spine. You need to question and counsel patients regarding a risk of severe allergic reactions, and there should be more aggressive medical and surgical management of cardiovascular disease. I'd like to leave you with a sense of the wide variation in facial appearance of patients with Loeys Dietz syndrome. You know, if you only paid attention to children who had very obvious outward facial features, then you would miss other individuals who have more subtle manifestations in the or outward manifestations, but may have just as severe cardiovascular manifestations that require aggressive management. I'd like to acknowledge both my research team and our clinical team, and really give a huge debt of gratitude to Paul Sponseller for the truly fantastic orthopedic service that he provides to Loeys Dietz syndrome patients and all other connective tissue populations, and to Gretchen Oswald, who is the genetic counselor that works in our clinic, truly a world's expert in Loeys Dietz syndrome and co-founder of the Loeys Dietz Syndrome Foundation in the U.S. I think the plan was to take questions after both presentations, but I certainly will be eager to address any questions that you have. Thank you for your attention.
Al, thank you very much. That's terrific. Very informative as usual. So we'll move on to our second speaker, which is Dr. Paul Sponseller. He's well known within the orthopedic community. He's the Department Executive Vice Chair, Orthopedic Surgery and Chief Division of Pediatric Orthopedics at Johns Hopkins. Dr. Sponseller has a medical degree from the University of Michigan. He completed his residency at the University of Wisconsin. He completed orthopedic and pediatric spine fellowships at Harvard. He also has a Master of Science in Business and Medicine and an MBA at Johns Hopkins. I'm not sure how your business card is big enough, Paul, to put all of those degrees on it. For anyone who participated at POSNA this year, you can attest that Paul has been very generous with his time and supporting us and getting this message out, and he's been a great supporter of the foundation as well. So thank you very much, Paul. I'm going to pass the ball over to you now and make you the presenter. So you're doing that right now. And I see that you have your presentation there. You can go to full screen, and you can start when you're ready.
Okay. Thank you, Joe. Can everyone hear me?
Yep.
Good. So this is the orthopedic part of the recognition, and I'd like to again acknowledge in pictorial form Loeys Dietz syndrome. There's Bart Loeys and Hal Dietz, who, as you heard, defined the gene for Marfan and then went in to recognize this form of it. I'd like to talk about how it affects the bones, how we can recognize it, and what we have so far in musculoskeletal experience for the hands, the spine, and other parts. First, starting with the ultrastructure, we have become aware that bone density and bone quality is impaired in Marfan syndrome, and we have several specimens of iliac crest bone that we have done 3D micro-CT analysis of in humans, comparing normal on the left to Loeys Dietz syndrome on the right. And you can see an obvious difference. Looking at that qualitatively in our lab, you can see there's decreased bone volume over total volume, trabecular number, thickness, spacing, and connectivity. Looking at the histology, there's also a visible difference in how the osteoblasts and osteoclasts relate to the matrix. On a non-LDS patient on the left, you can see osteoblasts with the asterisks and osteoclasts with the blue arrows in close proximity, whereas in the Loeys Dietz syndrome, you don't see that juxtaposition, and instead you see this more homogeneous mixture of fibrocytes-like cells opposed to the bone, both in the high power and the low power views here. So the way that the extracellular matrix relates to the bone trabeculae is different, and we have a lot of further work to do on that subject. Looking at a mouse model on micro-CT, you can also see a greater degree of porosity of the cortex, again, with Loeys Dietz mice being on the right, generously provided by Hal's lab. And we are defining the biomechanical properties and the cellular signaling abnormalities that are taking place to cause this difference in structure, remodeling, and connectivity, with the hypothesis that there is uncoupling of bone formation and resorption to lead to decreased remodeling and decreased mechanical properties of this bone. As Hal has just mentioned, clinically there's a typical triad of arterial abnormalities, hypertelorism, the bifid midline structures, and bone, joint, and muscle findings are extremely variable from patient to patient. The skeleton really represents the best opportunity for recognition of the disorder. You can't see the aorta, you can't see these vessels dilated, but you can see these skeletal findings, and that should alert, in many cases, the diagnostician to be able to recognize these patients for proper vascular and cardiovascular management and counseling. The ligamentous laxity, as you can see here in the knees, is often quite striking and evident elsewhere. Working closely with Hal's group, we had the unique opportunity to study a snapshot of these patients, and this was recently published. Looking at 65 patients, we found, as Hal said, a less impressive degree of arachnodactyly. We found that many of these patients, almost a quarter of them, had been previously diagnosed as Marfan syndrome, a smaller number as Ehlers-Danlos, Sprintzen-Goldberg syndrome, and many of these have a fairly strong family history of either recognized LDS or aneurysms. In the upper extremity, they do have long, narrow fingers, and often a positive thumb sign is shown here on the left, or wrist sign on the right. But they also have contractures, in many cases, of the lesser digits, especially the ulnar digits, but sometimes the thumb and metacarpal phalangeal joints, and it's very variable even from right to left side. In the hip, there's a small number who had DDH. One adult patient had AVN requiring total hip replacement, and protrusion is seen in about a third of patients, usually mild. We don't think that that seems to result in premature degeneration the way it does sometimes in Marfan. We had one patient who had a fairly striking progression of her acetabular development between the ages of 3 and 7 years, and you can see the narrowing of the teardrop and obvious protrusion and deepening of the acetabular sockets, again showing the suspicion of increased remodeling and perhaps pressure sensitivity of the bone in this high stress area. And I think the mechanisms for this will be very interesting when we finally understand what's causing this. Knee problems can include not only hyperextensibility, but often varus valgus, and in some mild cases, growth guidance may be appropriate, as you can see here, done with 8 plates with the hemiepiphysedesis effect. There's often medial lateral laxity in the collaterals, severe hyperextension and recurvatum, as you can see here, and weakness of the muscles. If the foot is also lax and weak, this makes the knee problem even more severe and important. Treatment may include bracing if it's feasible, and occasionally correction of major malalignments through bony osteotomies. Hindfoot valgus is often seen in these patients either spontaneously or after clubfoot releases. Most patients have some degree of a flat foot, and about a fifth have clubfoot, either unilateral or bilateral. We don't know why a small fraction of kids gets this severe foot deformity and why you have contractures and laxity coexisting in the same disorder. It may have to do with inflammation and repair of tendons and ligaments, but I think this will be a very interesting point to understand in the connective tissue world. Our usual approach to clubfoot in Loeys Dietz is the same as in other conditions with Ponseti casting. The success rate seems to be reasonable. 8 out of the 11 patients that were studied in our series did have a good response to Ponseti casting, albeit with some residual adduction or hindfoot varus, but a plantigrade and functional foot. The few patients that underwent surgery seem to develop a major degree of overcorrection, often going into valgus or skew foot, as you can see here, again illustrating the laxity being unmasked by this surgery. Most patients with Loeys Dietz syndrome have some degree of metatarsus adductus. Treatment is either just observed or stretching. It's rare that we have had to do any osteotomies in this population. A number will go on to the severe deformity of skew foot, which is a forefoot adduction with severe hindfoot valgus. Some of these result again from a zealous clubfoot surgery, but some are spontaneous. Most of them are treated observantly because they have a fairly daunting prognosis, but in some cases, a combined lateral shortening and medial lengthening can be helpful in improving their plantigrade nature. For the general flat foot that most patients have, my preference is not to use prophylactic orthotics unless the patient's having pain and maldistribution of pressure, in which case common sense can guide the use of an orthotic. There's a limited role for symptomatic surgery because, as we've seen both in Marfan syndrome and in Loeys Dietz syndrome, transfer to another portion of the foot will often occur from correction of the foot, and you really can't get a predictable result from ligamentous surgery or capsulotomies. One fairly safe option for the hindfoot valgus is to do a calcaneal osteotomy, redistributing the collapsing stress without performing a capsulotomy, and this can be done even in patients with osteoporosis and get a satisfactory result. As Hal said, many patients will have ingoing sternum or pectus carinatum. More common, however, is pectus excavatum, and in our series, a small number had surgical correction. Most, however, were preoccupied with their more severe cardiovascular problems. The spine is where it becomes even more interesting because these patients have problems all the way up and down the spine. One of the most striking features of the syndrome is congenital cervical abnormalities and instability, including formation defects, instability, or both. In the cervical spine, you see things that correspond to the bifid uvula and the sutural abnormalities at the upper cervical spine level. They often have formation defects in the anterior arch or the posterior arch, as you can see here. Some of them have just a curious off-center position of the odontoid within the arch of C1, which is not really a problem, but again illustrates the midline formation and symmetry defects that these patients have at this level of the skeleton. In the series I mentioned, a number had C1, C2 subluxation, either front to back or rotatory. We also had some with abnormal stenosis at C1, laxity at C2, 3, which we know is a predisposed area to this problem. And many of these patients have come on to surgery. In the thoracolumbar spine, the results of bracing are not known, but in most syndromes, bracing does not stop progression. It may slow it if started early enough. We do know that in Marfan syndrome, there's evidence that it works much less well than in idiopathic scoliosis, and we use it early, if at all, and not for some of the more severe cases when the curves are 40 and 45 degrees. Scoliosis in the thoracic and lumbar spine was seen in more than half of the patients, most of them in the braceable or surgical range. 3 patients in this series had posterior spine fusion, and we have to be careful, just as in Marfan syndrome, for junctional problems and adding on problems. I've illustrated a sequence here in a patient that I took care of. She had a surgical scoliosis, which we treated, and subsequently went on to a proximal junctional kyphosis, requiring a cervical to lower an occipital to lower lumbar fusion, as you can see here. So the stress concentration between her previously fused upper cervical spine and the newly fused thoracolumbar spine precipitated this junctional instability. We also have 3 patients who are being treated with growing rods, and that seems to be a useful strategy. And so far, we haven't had any notable complications with this treatment, either upper thoracic to lower lumbar or sometimes to the pelvis. Later on in life, you can see other problems such as premature lumbar degeneration and dural ectasia at all ages in about 2/3 of the patients. They really have pan-spinal pathology, and in some cases we see spondylolisthesis developing at a fairly early age, such as this patient here who started with a grade 3 spondylo at age 4 and went on rapidly to grade 4 or 5 spondylolisthesis. This patient underwent a posterior fusion elsewhere, but she developed instability at S1, S2 with plowing of the screws and required augmentation. Because of the scoliosis, she also had a growing rod inserted at the same time, and she required 2 revisions. First, an L5 decancellation, and then when that didn't unite, a Bowman procedure to help achieve stability at this level. Another illustration of the pan-spinal pathology is this patient who had an extensive upper cervical instability requiring fusion elsewhere, but developed severe junctional instability with critical respiratory distress, possibly from large airway distortion. And he actually had his kyphoscoliosis treated with growing rods, and he was again stabilized from the occiput down to the sacrum, and his respiratory function improved dramatically, requiring less oxygen and no daytime support, and this seems to have been a solution for his inflammatory problems. Fracture is also seen in these patients, often unusual fracture patterns, such as this girl who came for a routine clinic visit with a minimally symptomatic stress fracture of her femoral neck. This has also been reported in another patient. It probably would be even more evident if these patients were more active, but there is osteopenia and osteoporosis in a moderate number of these patients, which is currently being investigated. So in summary, these patients can be recognized by facial findings with wide spacing of their eyes and of the uvula, and also by some skeletal pairings such as Marfan-like appearance with club feet, unusual types of cervical instability with midline defects, and digital contractures. The ligamentous laxity at the knees especially, but also at the feet and elbows, is much more of a problem than seen in Marfan syndrome. And the syndrome is very pleomorphic, with each patient having a totally different constellation of findings from every other patient. The principles I'd like to stress are the importance of ensuring ongoing cardiovascular monitoring. In treating a clubfoot, try to be as conservative as possible with non-operative or minimally operative releases. Anticipate decreased bone quality when performing spine and extremity surgery. Examine the entire spine, including, as Hal said, C-spine flexion extension laterals, and looking closely at the lumbosacral joints. And anticipate junctional deformities of the ends of your constructs so that you don't fuse too short and avoid stress concentration. So I'd like to thank the Shriners Hospital System for promoting awareness of this syndrome. I'd also like to thank them for hosting the recent 2011 Marfan Foundation meeting in the beautiful city of Portland, which is shown here looking out the clinic window at this beautiful landscape. So thanks again, Peter, and thanks for everybody who's listening, and Joe as well. And I guess we will take questions now.
Great. Thank you, Paul. That's terrific. I appreciate it. So ladies and gentlemen, the attendees, you have at the bottom of your screen, so if you click on your participants panel, at the bottom of your screen you have a little hand, and if you click on the hand, it'll indicate and I'll open your microphone to ask questions. So if anybody's having a hard time to see that, if you just scroll to the top of your screen, put your cursor over the little green bar, click on participants, you will then see a window open. Click at the attendees and you'll see your name, and if you just click the little hand at the bottom of the screen, we will then open your microphone so you can ask some questions. So I'll stand by while you are finding the little hand at the bottom of your participant screen. Okay, so I'm going to just go through the different attendees. Andrea, do you have any questions for either of our speakers?
No, thank you very much. That was a wonderful introduction for those of us who are still learning about it. I appreciate it.
Okay, good, stand by. And I'm going to open up Dr. Jean Ouellette's mic. Jean, go ahead, you're live.
Hey, can you hear me?
Yep, go ahead.
So I guess my question is in respect to sort of a general orthopod or going through clinics, and I guess, when do you start getting antsy in respect to, you have a kid that has, let's say, a pectus, and scoliosis, and some club feet. Obviously, you know, the spectrum of the clinical presentation seems to be quite wide. So maybe if you could sort of tell us, Dr. Dietz or Paul, when, you know, what are the key things, you know, so if you see a bifid uvula, then right off the bat you sort of jump on that, or are there other orthopedic clues that, you know, you sort of put together and that brings you a bit of a higher suspicion to either start screening the patients? And that's the first question. I guess if you do you send them for an echo, send them for MRA, or what are your initial sort of investigation or screening tools?
Well, that's a very good question. I think clubfoot, when paired with any of the Marfan-like features, does have a high chance of being Loeys Dietz syndrome. In my own just general pediatric practice, I've actually come across 3 clubfoot patients that ended up having LDS, and I referred them to Hal, and it wasn't really coming from Hal to me, it was coming from my general pediatric orthopedic practice to Hal. So I think there's going to be a lot more recognition of this syndrome. And I think clubfoot, when paired with any of the Marfan conditions, probably should be, Marfan features should be investigated. And as far as how the diagnosis is made, you know, Hal can speak to that, but it's genetically based.
Al, would you like to make a comment?
Sure. I would fully agree with what Paul was saying. Even in our clinic, when people come to us with vascular issues that are known, if we see clubfoot, then Loeys Dietz testing is the very first testing that we would perform. Now, bifid uvula is really useful when you see it, but again, does not necessarily have to be seen. So if I did see clubfoot and pectus and some soft skin, that would be enough for me to move on to cardiovascular imaging, generally echocardiography, as an initial clinical screening test. The vast majority of children, even young children, will have aortic root involvement. But you know, again, I would have a very low threshold to send mutation screening of the TGFBR1 and TGFBR2 genes. This is now available in many commercial labs throughout the country and throughout the world. Most of those labs can have an answer back to you within a range of 2 to 6 weeks. So there's pretty quick turnaround. And most often insurance companies will cover this testing.
Thank you, Hal. Jean, do you have any other questions before I go on to John Scavone?
Oh, that's all right.
Okay, thank you very much, Jean. Jean Ouellette, I'm going to mute your mic, and John Scavone, your mic is now open. Please go ahead.
Can you hear me?
Yes, please. Thank you.
Excellent. So John Scavone from the Shriners Hospital in Northern California, and on our call tonight we have Dr. Sundeep Tumber, who's one of our staff anesthesiologists and also one of our pediatric anesthesia fellows, Sam Tafoya, who's from UC Davis. And I just want to make a comment, just a general comment for all of the cardiologists and for the orthopedists on this call. That is that this syndrome is a bit under the radar in the anesthesia community, and when we did a literature search, there was really a dearth of information, and so we had to look at the available medical literature to find out about what this disease precisely was, and we ultimately even were fortunate enough to contact Dr. Dietz to talk about some of the specifics of the management. This disease is really quite complicated. and should be undertaken only with great deliberation by the team, the entire team, orthopedists, the cardiologists, and the anesthesiologists. And I just wanted to add that.
Okay,
Thank you for those comments.
Thank you very much. John, does anybody else in your group have questions or comments?
Joseph, I see Kerry Milkey is logged on, but he doesn't have a phone or a set of headphones beside his name. But Kerry, I believe you have or had a patient, and I'd be interested in hearing your comments.
Well, Kerry just gave us a little icon for raising the hand. Kerry, can you hear us? Kerry, if you would like to type your question in at the in the chat panel, so click on chat, and you'll click on send to all participants, and below that you could then type your question in, if that's possible, and then we'll answer you. No, unfortunately, I don't see any typing happening from Kerry. All right. Peter, do you have Kerry's cell number? Do you want to call?
I don't believe it. Let me just check and see.
All right. In the meantime, while we're waiting to get that resolved, are there other questions? If you mind raising your hand, and if you can't raise your hand for some reason, then you can send me a message through chat. Just type in the box below where it says send to, and I will be happy to turn the mic on.
And Paul, I'll ask a question of you. I mean, you showed some of the deformities, you showed some of the surgery. Perhaps you could tell us, you know, once the diagnosis is made and once you've made the decision that you're going to do surgery, say you know, the spinal deformity correction or something like that. How do you prepare then for that surgery? What is the kind of the lead up, so you know as you begin your surgery that things have been covered and you're fairly comfortable proceeding ahead?
Good question, Peter. We generally always like to make sure that the aortic arch and heart have been recently imaged and followed. We will request a cardiac update if not done within the past 6 months at the most. Sometimes pulmonary involvement is needed. We will image the area with an MRI to look at dural ectasia in most cases, and try to scrutinize the potential anchor points with either good imaging with plain film, sometimes CT scans, so we can be aware of pedicle deformities and poor laminar arches. Most of these patients we will take care of post-operatively in the ICU so they can have proper cardiovascular management for the first night, if not more. The intubation may be slightly complicated by neck instability, but in most cases that is either stabilized or something that can be managed by fiber optic intubation. We do find slightly increased bleeding in most of these cases. We have not experienced anecdotally a high infection rate, really haven't had any infections in this population, so that seems to be not an increased risk. You know, those are the main things that we take care of.
Thank you, Peter. Kerry, I'm going to give you my cell phone number. It's 514-994-7074. Again, 514-994-7074. If you want to call me, and I'll ask your question for you because I don't think you have a mic attached or you're not connected. In the meantime, I'm going to go over to John Laurent. John, I just made your microphone live. Go ahead, please.
Can you hear me? This is John Laurent from Los Angeles Shrine.
You're on board.
Okay. 3 questions, and I, again, first apologize. What age are these generally discovered?
John, we're losing you. You're muting in and out.
Is there something I can do to improve that?
Okay, John, we're going to ask you to ask your question again because you muted in and out. Could you ask your question again, please?
It's a three-part question. The first is, at what age are these typically diagnosed? And I ask that because of the second two parts, which are the treatment if there's a cleft palatal deformity. Do they respond with a standard cleft repair in the same way, or is there other functional disabilities that preclude normal speech? And then the third question is related technically, which is if we place these children for a cleft repair in a neck hyperextension, are we putting the child at additional risk that we wouldn't be aware of because they weren't diagnosed early enough?
Those are excellent questions. The age of diagnosis is highly variable, ranging from birth to late life. We've had some people diagnosed at age 70 or 75, but most often in early childhood. Cleft repair, my understanding is that very typical practices are used for cleft repair. There's nothing different or special about the repair. We have, unfortunately, heard of a number of circumstances where people have had catastrophic complications after neck manipulation in the operating room, including paralysis and death. So we do believe that the cervical spine needs to be imaged, understood, and appropriately managed before the operation and in the operating room.
Well, that answers the questions, is that we would have to have a very high suspicion if the child presents before 1 year of age, which they typically would, that we wouldn't just march them in and expect them to be positioned normally and do well.
Right.
The real question is, on the follow-up of these cleft repairs, is their functional recovery the same as other children, or do they have additional encumbrance because of other factors?
No, our experience has been an excellent response to cleft repair without residual deformity or deficit.
Great. Thank you.
All right, thank you very much, John. I'm going to mute your microphone. I have on my cell phone right now, I've got Carrie on the line. I'm going to put him on the speaker and see if we can allow him to ask his question to Paul. So Paul, we'll give it a try and see if you can hear Carrie. Stand by.
Hear me?
Yeah, Carrie, go ahead, please.
Yeah. The picture I have has really profound skew foot deformity, and I'm wondering if this acts like typical skew foot deformity later on. I mean, we think that skew foot deformity has a pretty bad natural history. I did continued cuboid cuneiform osteotomies on mine, and it looked like I did nothing. I think part of it is due to the bone density problem. But what's your experience been?
Paul, were you able to hear the question?
I was. Thank you, Carrie. I think you're right. There's so much ligamentous laxity and muscular hypotonia that stress redistribution will happen, and I think you have to look carefully, I guess, at the ankle to make sure there's no valgus of the plafond, and I think the workhorse is doing a hemiepiphystesis if there is. Calcaneal slide is likely to be of some benefit, but I think in general, I'm not sure you can expect a predictable result from just doing hindfoot and midfoot osteotomies and getting the degree of correction you would with a non-connective tissue skew foot. And I think prevention is, part of the answer here, and again, a plea for avoiding radical clubfoot surgery, even though these patients may fail upon steady treatment, trying to do the minimum possible to perform a medial release or a posterior release and accept a little undercorrection rather than overcorrection, because I think it's more disabling to have a weak overcorrected foot.
Okay, thank you, Paul. Carrie, I've still got Carrie on my cell phone. Carrie, are you okay with that? Do you have a follow-up question or comment? All right, Carrie, I'll disconnect with you. Thank you very much for the call-in. All right, so that was Carrie dialing in. I'm going to just run through real quick and see if anybody has any questions. Sandeep, do you have any questions?
No, I don't. Thank you.
Okay. Thank you. Sarah, any questions?
No, I don't think so. Thank you so much.
You're welcome. Thank you. Raymond, any questions? Raymond, okay. Move on to Philip. Any questions, Philip?
I guess just one, just how common is it?
Excellent question. Al or Paul, would you like to take a stab at that, please?
I wish I had an excellent answer, but I don't. We've seen, as I mentioned, about 200 families in our clinic, but that certainly represents a ascertainment bias or a referral bias to our clinic. Current estimates for Marfan syndrome are 1 in 5,000 to 1 in 10,000. I get the sense that this might be 1 in 20,000, but that's purely a guesstimate at this point.
Thank you.
Paul, anything you want to add to that?
No, it's a syndrome that's been recognized for less than 10 years, and there are milder as well as more severe phenotypes. So I think many of the more mild patients are not yet recognized, and I think there will be a big wave in recognition in the next decade.
This is Joseph. As a comment, in Canada, we put a website page up on Yahoo, just a crummy website page in December. And between December and June, we got 40 individuals contacting us saying, where do I get treatment in Canada? To give you guys an idea, if that was the United States, because of the ratio, that would be the equivalent of like 400. So, and I've been talking to different clinics, and I found clusters anywhere from 25 to 120 in different clinics outside of Hopkins. So what we don't know really what the numbers are, just because it is so new, as Paul was mentioning, and we're still trying to collect the data. And that's part of what the foundation, one of our roles will be to put together a registry and biobank that will allow us to collect global data on the different patients. All right, thank you very much, Philip. I'll move on to Kathy. Kathy, do you have any questions?
No, thank you very much. I thought that was a wonderful presentation.
You're welcome. I'm going to move on to John Lee. Do you have any questions?
No, sir. It was very informative. Thank you.
Oh, you're welcome. John Scavone, back to you. Any other questions?
No, I just, can you hear me okay?
Yep, you're good.
I just want to just reiterate a tremendous thank you from all of us. I mean, it's just an excellent review, and we actually consider those of you that are running this thing to be a celebrity in your own right. So we are very, very appreciative of this information.
Thank you. We're lucky to have Dr. Sponseller and Dr. Dietz on our team, and they've been terrific, and of course with Gretchen backing them up. Thank you. John Lawrence, anything else?
No, thank you very much. A great talk. Appreciate it.
Okay, thank you. Jean Willette, anything else?
Oh, things are good. I think, I guess from a maybe just insight in respect to upcoming research or access to patient information and so on, do either Dr. Sponseller or Dr. Dietz, you have ongoing projects regarding these patients? And if we do come across patients, are you looking for recruitments or stuff? Or?
Oh, good question. Al, Paul?
So we certainly have many active clinical research protocols. I think a good point of reference would be the Loeys Dietz Syndrome Foundation in Canada and the United States. We usually try to coordinate patient recruitment through the foundations. So we really appreciate the offer in helping with that, and I think it's going to be a critical need moving forward to fully define the natural history of this disease.
Thank you. Paul?
And orthopedically, we have some registries looking at the prevalence and importance, especially of the cervical spine abnormalities, which are probably the most unique features of this disease. The thoracic and lumbar treatments are somewhat well known from Marfan work, but the cervical spine is kind of a new part of the ball game. So we're trying to look at the prevalence and response to treatment of the cervical deformities. One thing we really are excited to look into is ligament biology in response to injury and healing in this condition, as well as bone coupling and uncoupling and potential response to therapy as well. So a lot of research is starting to be underway, but we hope to have more answers in the next few years.
Okay, thank you very much. Thank you, Jean. Going over to David. David, do you have any questions? Okay, and moving on to call-in user number 4, which I believe is Sam. Do you have any questions?
Hi there. Yes, just wanted to thank you as well for this very informative session. Very specific to cardiovascular status in these patients. Sometimes they will come with an echo before their surgery. And I'm just wondering, are there any aortic root dimensions that we should be looking for as red flags that these patients might be at higher risk for rupture, that we should maybe have in the back of our head that they might not tolerate an anesthetic? Is there anything that sort of specific characteristics that we should be looking out for?
Yeah, in a patient with very severe outward features of Loeys Dietz syndrome, for example, with craniosynostosis and cleft palate, I would be really concerned about a vascular event even at a very young age, even less than a year of age. Aortic dimensions, we know more about how to interpret risk in correlation with aortic dimensions for Marfan syndrome. Given the new appreciation of this condition, there are some broad rules, but not great rules. I think that it is important to standardize the aortic measurement to age and body size, and there are nomograms available to do that. I know on the National Marfan Foundation website, and perhaps those are or will be included on the Loeys Dietz syndrome website. But I would. In any child that's very severely affected, I would get a dedicated assessment by a pediatric cardiologist that's very familiar with this condition. For more typically affected individuals, I think you can feel comfortable if the aortic root measurement is less than about 3.5 centimeters. Between 3.5 and 4 centimeters, again, I think a very dedicated cardiovascular evaluation should be done to determine if the patient's in good shape for surgery.
Okay, thank you.
Sure.
All right, Sam, thank you very much for that question. And I'm going to go to Andrea. Any questions?
No, thank you very much again.
Okay, terrific. So it looks like we don't have any other questions. I'm going to just open it up to Peter, Hal, and Paul. Do you have any questions or comments? Peter.
Well, no. As so many people have said, this has really been outstanding. Yeah, I want to again thank Hal and Paul for taking the time to do this fine educational event this evening. I'm still committed to doing my part as the CMO for the organization to make sure that those who are unable to participate this evening have an opportunity, to, if they have the time, to actually watch the presentation. So I appreciate the fact, Joseph, that you recorded it. The other thing that I would ask you, when we were together in Poznan, you gave me a coil-bound kind of handout, Loeys Dietz syndrome, encourage education, foster research, provide support, and then a number of one-sheet things, correct diagnosis, caring for cardiovascular problems, and so on. And I'd certainly be quite prepared to, if you had electronic copies of those, to distribute those out to the 22 hospitals as well.
Sure, be happy to. I'll arrange to get you that as well, Peter, with the recording and the presentations from tonight. So thank you.
Perfect.
For that. Appreciate that very much. Hal and Paul, anything you'd like to add?
I'd just like to thank everyone for participating and for demonstrating their eagerness to learn more about this condition. The only other thing I'd add is that sometimes I'm contacted by physicians who have a subtle suspicion and they almost feel timid about asking. And you know, I'm always thrilled that people are maintaining a high index of suspicion. And I think the right rule to live by is if there's any doubt, push the issue forward. So thank you again for being interested in this condition.
Thank you, Hal.
Hal, would you mind if included in the material that we send out your appropriate contact information?
Oh, that would be fine. That would be great.
Good. Thank you.
I'll take care of that as well. Thank you. Paul?
Well, thanks everybody for all your questions. I always learn a lot by doing these things and listening to Hal. So thank you everybody for participating and stimulating this discussion.
You know, it was neat because it really was a multidisciplinary group. So we had some PD pods, some anesthesiologists, a plastic surgeon, one of our burn surgeons, and one of our radiologists. So I'm thrilled with the distribution.
Thank you. It's terrific. Gretchen, are you still there with Hal? Is there anything you'd like to mention or say?
Oh, just again, thank everyone, and please feel free to contact the foundation, info@loeysdietz.org, or myself for any questions or concerns, or please direct patients if they're looking for more information to the foundation.
Thank you, Gretchen. And I just want to reiterate that to everybody, to the whole medical community. The foundation, our role is to provide information not only to the patients but also to the medical professionals. And we get a lot of calls from families that are really at their wits' end. They don't know what to do, and they ask us, you know, where do I go? Who do I go see? So we try to plug them into doctors that are familiar with the disease and know how to treat it. I can say from personal experience that the team at Hopkins has been very receptive, starting to when I reached out to Gretchen on Christmas Eve 2009, and I was a distraught parent, right up to Paul and Hal making themselves available. So I can tell you that it's a fantastic core team that is very supportive and very committed to helping everybody, whether it's patients or really medical professionals. So I'd like to say thank you very much. Peter, I'd like to thank you very much for organizing this. Peter, I know you were on vacation. I don't think it's true because you probably got 20 emails back from you on your vacation, so I'm not sure that it was your vacation or what, but thank you very much for the responsiveness and the support, and all of your staff, particularly Donna, who helped me put this together. And Hal and Paul, thank you very much, and Gretchen for taking the time tonight. I know it's family time, and I know it's also holiday time, so thank you very much for that. Sure. I will undertake, Peter, to make sure that you get the spiral-bound presentation, which is the medical presentation, the fact sheets, also the checklist that gives you all the different attributes that you should look at, as well as these presentations, Dr. Dietz's contact information, and the recording so that you can distribute that internally.
Perfect.
All right, so I'd like to say thank you to everybody. I would just ask Paul, Hal, and Peter to stay on the line, and if everybody else, if you're good to go, you can just disconnect. And I wish everybody a good evening. Thank you very much. So for our presenters, if you just stay on the line for 2 seconds, please. And our guests are just dropping off. I'm going to stop the recorder now.